Good evening, ladies and gentlemen. Welcome to monthly clinical update in neonatal session of February 2023, which is organized by Ceylon Association of Neonatologists. The topic we are going to discuss today is evaluation of direct hyperbilirubinemia in infancy. So why we need to talk about this topic? I would like to highlight the importance of it from the point of pediatric and neonatal clinical practice. So the cholestatic jaundice is a rare condition which is affecting about 1 in 2,500 births. But the jaundice is extremely common. We encounter jaundice in our day-to-day practice in most benign conditions. But as neonatologists or pediatricians, we must have a high index of suspicion for cholestasis so that the best possible outcome can be attained from the infant who is suffering from this potentially life-threatening underlying condition. So we have selected and invited a best speaker who can speak about this topic. She is Dr. Meranti Fernando. She is a senior lecturer at the Faculty of Medicine, University of California, and she is the senior consultant pediatrician at Colombo North Teaching Hospital, Ragama. She has special interest in this field, that is pediatric hepatology and liver transplantation in children. For that, she has qualified in additional qualifications, such as she pursued a clinical fellowship in pediatric hepatology and liver transplantation in the liver unit at Birmingham Children's Hospital, which is one of the 3 pediatric liver transplant centers in the UK. And with her knowledge, she was able to set up a pediatric liver transplantation program in our country. So she is the member of British Society of Pediatric Gastroenterology as well. With her sound knowledge on pediatric hepatology, I would kindly invite Dr. Meranti Fernando to deliver her lecture on evaluation of direct hyperbilirubinemia of infancy. Over to you, Meranti. We can see your slides.
Yeah, can you hear me?
Yes, we can hear you.
Yes, and I hope you can see my slides and my video as well.
Yes, it's clear, Meranti. We can see the slide.
Right, thank you so much. So we can start. Good evening, ladies and gentlemen. Thank you, Dr. Jitma, for that kind introduction. And thank you, Ceylon Association of Neonatologists, for inviting me to deliver this talk this evening on evaluation of direct hyperbilirubinemia in infancy. From the first slide, I would like to highlight these 3 pictures I have used to introduce my talk today. I have used a baby who has got jaundice because I don't think I can talk about direct hyperbilirubinemia without talking about jaundice, as Dr. Jitma mentioned. It may be out of a lot of causes, a lot of children you see with jaundice, maybe a handful of children who come with direct hyperbilirubinemia. However, it's very important you do not miss the crucial diagnosis, maybe the time-sensitive diagnosis like biliary atresia from those few people you encounter with direct hyperbilirubinemia. And the second picture I have included liver and hepatobiliary system. The reason for that is the direct hyperbilirubinemia or conjugated hyperbilirubinemia is always coming from the hepatobiliary system. There is no other organ in the body which would account for direct hyperbilirubinemia. So it's quite easy, you know where the problem is. It's in the hepatobiliary system if you have an infant with direct hyperbilirubinemia. Thirdly, I wanted to include a picture with pale stools for the starting slide. That is again to highlight the importance of looking at the stool color, detecting tail stools, and early referral in view of biliary atresia. Because that is the cardinal cause or the diagnosis out of all direct hyperbilirubinemias where we are interested at, because early CASI would save many lives. Having those thoughts at the outset, let's proceed with the presentation and the talk today. I would like to start my talk with a little story. It's very important that we know what is direct hyperbilirubinemia, because sometimes we get the numbers, total bilirubin of this much, direct or conjugated fraction means this is the number, this may be the percentage. We might think twice, is this direct hyperbilirubinemia? So let's look at this story. A 4-week-old baby is referred due to persistent jaundice. When we perform the bilirubin, the total bilirubin is 110 micromoles per liter. The direct value is 85 micromoles per liter. If you look at the percentage, it's more than 77%. Is this direct hyperbilirubinemia? You would say it's very easy. Yes, it is direct hyperbilirubinemia. The direct value is quite high out of the total, and the percentage is more than 20% from our medical student teaching. Yes, that is direct hyperbilirubinemia. When it comes to practical scenarios, what about these values? If the total bilirubin is 70 and direct bilirubin is 35, where it would come to 50%. Is this direct hyperbilirubinemia? Secondly, a total of 20 and direct of 5, 25%. What do you think? The direct bilirubin is quite low in number, though it comes as 25%. Again, the total bilirubin of 180 and direct bilirubin of 35, 19.4%. Less than 20%, however, the direct value is 35. What do you think? Out of these three scenarios, when would you say that is direct hyperbilirubinemia? And when would you need to think about evaluating this baby? So it's very crucial you know the definition of direct hyperbilirubinemia. There are many definitions which have come forward to define conjugated or direct hyperbilirubinemia. If you look at the Nature Gastroenterology and Hepatology reviews, they have defined direct hyperbilirubinemia in 2 ways. If you have a total bilirubin of more than 85, you can take 20% as direct hyperbilirubinemia. Or else if you have a lower number like less than 85.5 in total, they would recommend that taking the number of 17 to define direct hyperbilirubinemia. By looking at it, it looks a little bit complicated. You have to remember the total value, you have to remember the value, percentage, everything is there. So I thought we can make it more simplified. NICE guidelines have actually made it quite simplified and it's quite practical, I would say. They would say a value of direct bilirubin more than 25 micromoles per liter, you can say that is direct hyperbilirubinemia. So that is quite easy and practical, I believe. So what I would recommend is to remember this value, 25 micromoles per liter. Just forget about the percentage, forget about this 85.5 or certain other classifications, just make it quite simple. The definition is more than 25 micromoles per liter of direct bilirubin or conjugated bilirubin as per NICE guidelines. And at the same time, remember the conversion, because certain laboratories, they perform bilirubin in milligrams per deciliter, so it might come as small numbers like 1.5, 2, 3 like. So just multiply it by 17 if you are used to micromoles per liter. Having this definition in mind, where we would agree to proceed with this 25 micromoles per liter, we shall look at these scenarios again. The total bilirubin of 70, direct bilirubin of 35. We agreed to not to look at the percentage, but to look at the number. So this is more than 25. So yes, we would take it as direct hyperbilirubinemia. What about this? Total of 20 and direct of 5. If we would have taken the percentage, we would have gone wrong because it's 25%. Are we going to proceed with evaluation? No, because it's just 5 in number, so it is not direct hyperbilirubinemia. You don't need to worry about it. What about this? It's less than 20%. However, the number is 35 when it comes to direct hyperbilirubinemia. Yes, though it is less than 20%, you need to proceed with evaluation. So again, I think I have emphasized in both of the number is number 25, micromoles per liter, the direct value when you want to say, yes, this is direct hyperbilirubinemia. So we'll stick to this definition and just remember the conversion if you get it in milligrams per deciliter. So I hope at this point you are quite confident in diagnosing or defining direct hyperbilirubinemia. Let's go back to the cellular level. How would this direct bilirubin or conjugated bilirubin appear in the blood? We all know that's a mechanism of red cell clearance in the body. By macrophages, it gets cleared and it produces unconjugated bilirubin. And one of the functions of the liver is conjugation of this unconjugated bilirubin to make it easy to be excreted. So liver is expected to conjugate this bilirubin. And then liver is expected to transport and export this into biliary canaliculi and biliary system where it would get excreted with feces. What would happen when the liver and hepatobiliary system doesn't work properly or when there is obstruction? Conjugation happens, but the transport or export might be impaired. It might be at large duct level, maybe at common bile duct, maybe at the level of hepatic ducts, or maybe at cellular level or canalicular level. Ultimately, the result would be raised conjugated or direct bilirubin value. Basically, to remember, it originates from the hepatobiliary system. It is mainly due to obstruction, maybe at canaliculi level or extrahepatic. The cardinal clinical feature when we talk about direct hyperbilirubinemia is jaundice. It is a baby with jaundice where you would think about hyperbilirubinemia, where it could be indirect or direct. Usually at a total bilirubin of more than 40 to 50 micromoles per liter, you might see jaundice to the naked eye. When it comes to direct hyperbilirubinemia, it usually has a greenish tinge, which would imply there's some problem with the liver and hepatobiliary system. If you look at the baby who's in the right side, you can appreciate that greenish tinge of jaundice. If you have a baby where you suspect direct hyperbilirubinemia or just any hyperbilirubinemia, maybe direct, maybe indirect, for you to differentiate that, the next thing you could ask is the color of stools. It is very important you inquire and you examine for the color of stools. Sometimes in our busy clinics, we might just ask from the mother or the caretaker, what about the stool color? Is it normal? Mother might say, the first child, she might not know what is normal, what is abnormal. She might say, yes, stools are good. But it might be prudent to take a couple of seconds and examine the color of stools by your naked eye. Sometimes it might be just misleading where you have a nappy full of urine with dark urine, which might imply pigmented stools, but it's actually not pigmented. So it's very important that you might take a sample to a specific bottle and then examine it for pale stools. On the other hand, in certain scenarios, you might get intermittent pale stools or partially pigmented stools. Again, it's very important you pay extra attention for these scenarios rather than getting convinced the stools are pigmented. This is the stool color chart. Stool color chart is very popular in many countries, especially in view of detecting early detection of biliary atresia. Fortunately, we also have this included in our CHDR. However, it's not very much sure that how many of the parents or families would go through this. Sometimes when you encounter in the clinics, the parents did not know that there is something like that in the CHDR. So as neonatologists, pediatricians, trainees, it might be quite important on discharge to highlight the fact that there is something like this in the book, where you are expected to go through this and compare your baby's stools with the stool color card. And in your busy clinic, if you can't have a stool sample to be examined, you might take the CHDR and then show this picture to the parent and ask which color you would say your child's stools are. Because they might say this is normal, this is abnormal, that is their interpretation, but this is quite objective. So I would really recommend to emphasize on using stool color chart for the families, parents, as well as for the clinicians. If you have a child with jaundice and you have examined for stools, stools may be pale, stools may be pigmented. Sometimes you can have direct hyperbilirubinemia with pigmented stools. The next thing would be you would perform a blood test. You would perform total bilirubin and direct bilirubin. If the direct bilirubin is high, as per the definition we discussed already, then you are going to go ahead with the evaluation. Sometimes it's a nightmare because you would think, okay, how far I should investigate, how aggressive I should be in investigating, which child would need a liver biopsy, which child would need genetics. Do I really need to refer this child to a tertiary center? So all these questions would come in. What I would suggest is a stepwise, practical, and a cost-effective approach in evaluation. Because if you read a textbook, if you just Google, you might get maybe more than 100 courses for direct hyperbilirubinemia in an infant. So, especially in the current economic crisis, are we going to do all the investigations simultaneously? I know we would not. However, what are the critical diagnoses we would consider to exclude first? Possibly we would consider about those diagnoses, those differential diagnoses first, and then you would follow a stepwise approach, which would be cost-effective. If I give you an example, maybe you have a child or baby with direct hyperbilirubinemia, just 3 or 4 days of hospital admission, and you have not still excluded biliary atresia. So send in metabolic screening simultaneously without having specific features to point towards the metabolic etiology would be a waste of money, because the lab who's receiving the metabolic screening would not know how important this is. They would assume, okay, a clinician has sent this investigation, possibly it's needed, and they might proceed with metabolic screening. However, you have still not even excluded biliary atresia. So likewise, possibly we would go ahead with a stepwise approach, which would be practical and cost-effective for a country like ours. In addition to that, picking up the red one, as I've shown in the picture, the picking up the red one is very important. There may be many children who have got direct hyperbilirubinemia with innocent benign causes, and the causes which might improve and the causes which might not have a treatment. However, there are red ones where you really need to pick up quite early and intervene early. So in the next few slides, we will look at who are these red ones and who can be left behind a little bit till you sort out the red cell. In evaluation of direct hyperbilirubinemia, I would like to suggest this approach. You will have 3 zones or 3 steps. Firstly, you have the red zone where you would have kids who would need immediate intervention. In the yellow zone, you would have kids or children who would have, differential diagnosis or underlying diagnosis which would warrant close follow-up and sometimes specific treatment and follow-up. So you can perform stepwise evaluation, but not emergency. Thirdly, you might have small babies who have got very low level of direct bilirubin, who are thriving well, examination normal, who had sustained sepsis. Now picking up with nutrition, you might follow them up. You have excluded sinister things. This might self-resolve. So it's very important as pediatricians, neonatologists, we categorize these children to these zones and then plan our management. Who will belong to red zone? These are the 2 questions I would ask. Number 1, what about the stool color? Are they pale? So our main concern is excluding biliary atresia. Because if you refer them for early Kasai portal uterostomy, that would save a life for many years till they get the liver transplantation. If you miss a biliary atresia and if the CASA is delayed, they would either need liver transplantation at a very young age or they would die. The success of very early liver transplant is quite limited because they are very small in size, they can't withstand the prolonged surgery, so they're likely to die or kind of less success we would expect. So it's very important that we detect biliary atresia very early and refer them for early CASA. So my number one emergency would be tails. If I suspect biliary atresia, I would aim to refer the child for cholangiogram within 2 to 3 days. The next one would be neonatal acute liver failure. The question I would ask is, what is INR? What is the prothrombin time? If there is INR more than 2, not corrected with vitamin K, after 3 doses of 8-hourly vitamin K, intravenous 1 milligram, then there is neonatal acute liver failure. So those are the 2 emergencies which would come under AIDS. If you have a child who is suspected to have biliary atresia, you will immediately refer to the surgeon to go ahead with cholangiogram and CASA portoenterostome. If you have a baby with neonatal acute liver failure, you will look for the cause, you will implement the specific management. What would be the approach if you have a baby who is having tail stools and suspected to have biliary atresia? You will have the baby admitted. You will perform liver blood test. What do I mean by liver blood test? You will perform liver enzymes, albumin, clotting, all the bloods related to liver function. Would they confirm biliary atresia? The answer is no. They might suggest there may be different degree of transaminitis, AST may be risen for hundreds, maybe 100, maybe 300, but it's not really going to say whether this is biliary atresia. Usually gamma GT is raised in biliary atresia. However, there have been cases where gamma GT is low and diagnosed to have biliary atresia. So you can't trust, but you will perform. Albumin and prothrombin time are quite important. If it's a late diagnosis of biliary atresia, they would be impaired. If they are preserved, that means the liver synthetic functions are preserved. That means you are quite good in diagnosing and you can refer the baby to the surgeon quite early. Immediately you will perform an ultrasound scan. You will request an ultrasound scan, which should be a fasting scan. What would the radiologist say? Radiologist might say there is typical triangular cord sign, contracted gallbladder, please refer to the surgeon. Or radiologist might say it's not conclusive or gallbladder is visualized. If the scan is suggestive, it's easy. You will refer to the surgeon for cholangiogram. If the scan is not suggestive, then what would you do? If the radiologist say gallbladder is present, still you have tail stools, please do refer to the surgeon for cholangiogram. Because if you have biliary atresia, the atretic segment beyond the cystic duct, you might see the gallbladder on ultrasonography. However, it would still be biliary atresia if the atretic segment is beyond the cystic duct. So please do refer to the pediatric surgeon and get the cholangiogram done. Though ultrasound scan is not suggestive if you have persistent tail stools. A word about neonatal acute liver failure. Actually, I would not go into the details of this slide because it's beyond the scope of this lecture today. However, these are the causes which would commonly cause acute liver failure in neonates. So you will have general management, supportive care if you diagnose acute liver failure, and specific management if you suspect galactosemia, you will stop breast milk, and especially if you suspect herpes simplex virus infection, you really need to start acyclovir early because that's a killer likewise. So those are the 2 key diagnoses which would come under red zone, biliary atresia and neonatal acute liver failure. So if you get a baby with direct hyperbilirubinemia, firstly, please look at these 2, provided there are no straightforward causes. Secondly, your yellow zone. These are other common differential diagnoses you would get in neonatal unit or pediatric follow-up in babies with direct hyperbilirubinemia. It could be due to infections like congenital infections or bacterial sepsis. could be due to genetic or metabolic disorders like Alagille syndrome, progressive familial intrahepatic cholestasis. All these genetic disorders actually can wait a little bit because there are no time-sensitive interventions like Kasai. If you diagnose it today or maybe 3 days later, which wouldn't do much harm. And usually you need genetics to diagnose in the current context. Surgical causes, polydophal cyst, biliary sludge, or stones would be seen on ultrasonography. Perforation of the common bile duct could occur in neonatal setup in very sick neonates where they would be quite sick, having abdominal tenderness and ascites. Ultrasound scan would show, or sometimes in developed countries, they might do MRCP in small babies to diagnose CBD perforation. Other causes like intestinal failure associated liver disease. What are these IFLDs? This is actually the children who would come under short gut syndrome, who would have causes for delayed establishment of enteral feeding, who would be on parenteral nutrition for a long time. All these children would come under intestinal failure associated liver disease. So these causes would come under yellow category where you can buy little time for diagnosing as well as management. And some of these causes have got specific management like galactosemia where you would stop breast milk. However, most of the causes would not really have specific management. What would you normally do is you will start them on ursodeoxycholic acid and fat-soluble vitamins and wait. And when it's needed, you will perform liver transplantation, except for infections and surgical causes. Nutrition is very important when it comes to intestinal failure-associated liver disease, especially establishing and improving on enteral nutrition. I would say enteral nutrition is a medication which would enhance the recovery of liver disease. We would consider it as a medication. This is the list of other causes just to tell you how broad they are, but we are not going to investigate for all these things simultaneously. It should be a very stepwise approach where you would use your clinical features and clinical suspicion and then go for specific investigation. These are common scenarios in neonatal ICUs. The children who have prematurity, low birth weight, and sometimes having necrotizing enterocolitis and have reasons for delayed establishment of enteral feeding, they might get biliary sludge, biliary stones, or sometimes with hemolysis, they can get inspissated bile syndrome. Cholestasis of multifactorial origin. Again, babies who have had sepsis, who have been on multiple antibiotics, might have cholestasis or direct hyperbilirubinemia with some degree of transaminitis, which would resolve when you treat the underlying diagnosis. And there had been cases with severe cholestasis where direct bilirubin would rise up to 300, 400, following E. coli and Acinetobacter sepsis, where that would improve gradually when you treat the sepsis effectively. Intestinal failure associated liver disease we have talked about, and spontaneous perforation of the common bile duct again can occur in the neonatal ICUs when they are quite sick and they can have biliary ascites. I think my talk will be incomplete if I don't talk about neonatal hepatitis syndrome. This is a very common terminology we use when we have a baby with direct hyperbilirubinemia. What is neonatal hepatitis syndrome? It is actually an umbrella term. It is not a specific disease. It's having hepatitis in a neonate. Hepatitis is you have transaminitis, rise in AST/ALT, as well as you have inflammation evident on the biopsy in a neonate. That would not really tell you what is the cause, what is the prognosis and outcome. If you go back 10 years, you will have a lot of causes, a lot of children who had been put under this term of neonatal hepatitis syndrome. But nowadays, with the advancement of the diagnostics, we have children be labeled for specific diagnoses or diseases would not really come under neonatal hepatitis syndrome because they have specific diagnosis, especially with the help of genetics. So actually the neonatal hepatitis syndrome is an umbrella term and a crude term which would come for the causes where you really can't find a diagnosis. You have a baby with direct hyperbilirubinemia and hepatitis, but you really haven't found a reason for that. So it's not really a cause. If somebody says there's a baby with neonatal hepatitis syndrome, that actually doesn't mean the etiology. And cholestasis undiagnosed may be a better terminology because that wouldn't give you the reassurance. If you say this baby has neonatal hepatitis syndrome, that would give you reassurance. Okay, that's a diagnosis. However, actually there is no diagnosis. So cholestasis of undiagnosed etiology may be a better terminology rather than neonatal hepatitis syndrome. So far, we have discussed about our red zone as well as yellow zone. Now we are approaching to our blue zone, which is quite benign. If you have a baby with low degree of direct hyperbilirubinemia, whose current clinical examination is normal, a thriving baby, relatively low and decreasing trends of bilirubin and liver enzymes, and no cause found with investigation. You might ask me, in medical student days, we have learned if you have a baby with direct hyperbilirubinemia, it's always pathological. So how would I say it's benign? Yes, it is pathological. You might have had the sepsis, you might have had drugs, or you might have had delayed establishment of enteral feeds. You might have had reasons for this direct hyperbilirubinemia. However, now the child has come out of these reasons and this is improving. So we can put this baby under blue category and observe. And if you see these factors, you might not perform genetics, you might not perform metabolic screening, you will just observe. So that is the cost-effective practical approach. Having discussed those three zones, I would like to emphasize on the role of investigations and their interpretation. Because again, in our clinical practice, it's quite common to perform liver blood test, ultrasonography, liver biopsy sometimes we would consider. So it's very important to know when to consider and how to interpret. Let's first look at the liver blood test. Now we know the definition of direct hyperbilirubinemia. It is more than 25 micromoles per liter. If you perform other liver blood tests, how are you going to interpret them? What about transaminases, AST, ALT? Are they really useful in finding out the cause? Should we be very worried about a baby who has got 200s of bilirubin and maybe 400s of bilirubin in another baby? How are we going to interpret it? It's actually not very helpful, the transaminases. It can go up and down, but it would not really point towards a diagnosis. Unless the transaminases are rising very fast and it's above 1000, I would not really be worried about between 200s and 500s. No much difference. And they would not be helpful about a specific etiology. Gamma GT helpful sometimes. Usually in Alagille syndrome and biliary atresia, you get high gamma GT cholestasis. And normal or low gamma GT cholestasis would point towards a progressive familial intrahepatic cholestasis or bile acid synthetic disorder. So it's helpful. Alkaline phosphatase, is it helpful? I would say not really, because again in small babies with their growing bones, it would be high anyway. So it's not really helpful. What about albumin and prothrombin time? They are synthetic functions of the liver. So they are helpful, basically not to find out the reason, but to look at the pre-existing damage. If you have a baby with direct hyperbilirubinemia coming with prolonged prothrombin time, you might think about neonatal acute liver failure. In addition to prothrombin time, if albumin is low, then you might think about delayed presentation of chronic liver disease or biliary atresia. So they are important in view of prognostication. One important fact I wanted to highlight was improving levels of bilirubin would not really exclude sinister causes. I've seen cases with biliary atresia where you might have very low degree of bilirubin like 70s, 50s with pale stools. And sometimes they just go down. If you perform delayed bilirubin today, it's 70 and tomorrow it comes like 55, but still pale stool. So please do not get reassured if it comes down slightly and it's coming down. No, if there is pale stools, you should be worried. What about ultrasonography? We know we need to starve a baby for at least 4 hours if we need to get good view about the hepatobiliary system. And this is a very useful investigation in good hands, experienced hands with small babies. If you think about biliary atresia, you might see typical triangular cord sign, or you might not see gallbladder, or you might see a contracted gallbladder. However, a normal gallbladder would not exclude biliary atresia. Diseases like polydocalcist, gallstones, CBD perforation, again would be diagnosed with ultrasonography. What about HIDA scan? What is the place for HIDA scan if you have a baby with direct hyperbilirubinemia? When I discussed about the approach for a suspected biliary atresia, I actually didn't mention about HIDA scan. What was the reason for that? Most of the recent studies have found HIDA scan would unnecessarily delay the diagnosis of biliary atresia because HIDA can have false positives and false negatives. In most of the centers, you do not have this facility, and even if you have the facility, the waiting list is maybe 1 or 2 weeks. So it would delay a diagnosis of biliary atresia. So most of the centers, even in developed world, they would discourage HIDA scan. However, if you decide to perform in a child maybe was presented quite early, less than 4 weeks, where you have time to diagnose biliary atresia, it's not late, and you have intermittent pale stools, and you are not sure about the pale stools, sometimes it's pigmented, sometimes it's pale, slightly high bilirubin, MRGT just at the margin, then you might use this investigation cautiously. Having said that, if you have a baby who's coming after 6 weeks with pale stools, do not waste time for HIDA scan. Go ahead with cholangiogram. Intraoperative cholangiogram, the gold standard to diagnose biliary atresia. How is it performed? It is performed by the surgeon. Their surgeon would put the child under anesthesia with the help of the anesthetic team and then open to the tummy. Firstly, the surgeon would see the biliary tree to the naked eye. To the naked eye, if the biliary tree is quite ectatic, there is no need to perform a cholangiogram. But if the surgeon has seen a biliary tree and not sure about biliary atresia, then they would perform a cholangiogram by injecting a dye to the gallbladder and looking the flow up and down. That is the way you would perform a cholangiogram. If there is a block, then they would diagnose biliary atresia. What's the place for liver biopsy? It's a common question people ask. When you have a baby with direct hyperbilirubinemia and the ultrasound scan had been quite reassuring and you don't really have pale stools, but still having direct hyperbilirubinemia, mostly the clinician would ask, shall I proceed with the liver biopsy? Actually, in the current context, the use of liver biopsy to diagnose an etiology or a disease in a child who's coming with direct hyperbilirubinemia is very minimal. If you recap the etiology for direct hyperbilirubinemia, if it is an infection, you are not going to diagnose it with the liver biopsy. If it is biliary atresia, you are not going to waste your time by doing a liver biopsy. It's not needed for you to diagnose biliary atresia. If it is a surgical cause like polydocalcist, CBD perforation or stones, then again you are not going to do liver biopsy. What about genetic and metabolic causes like progressive familial intrahepatic cholestasis, maybe Alagille syndrome? In the current context, I would say again no, because the ideal, the state of the art investigation would be genetics. Because liver biopsy is invasive, sometimes in certain diseases it might cause detrimental bleeding, and it's quite unpleasant. And most of the time you would come with the umbrella term. It would say giant cell hepatitis, it would say neonatal hepatitis, would not really say this is the diagnosis. So then what's the purpose of doing liver biopsy for this particular reason? Nevertheless, liver biopsy is very helpful in certain indications in pediatric hepatology. However, not in direct hyperbilirubinemia in the current era. Genetics, very important. The limitation had been the money, the cost. However, it's very important if you can perform genetics, you are very confident about the diagnosis, especially for genetic and metabolic causes. It's very helpful not only for the index case where it will facilitate specific treatment and prognostication, it is helpful for the family, for the existing children as well as for future family planning. Nowadays, we do have assisted fertility methods, in vitro fertilization, we talk about those things. So pre-implantation genetics would facilitate having a healthy baby. So it's very important you consider genetics in these babies. Sometimes rather than wasting multiple clinic visits and the money used for that and maybe the other investigations, collecting all the money and allocating that for the genetics would be useful if you think practically, because that would give you the diagnosis. Otherwise, you are just going around the corner, you are not finding anything. Babies coming to the clinic every month, every week, you are still at the same place. So make use of genetics. I know it's a limitation when it comes to money, but sometimes with donations and maybe a family member who can help, we really need to consider genetics in the current context. I'm coming to the last bit of my lecture today, the medications and management in a baby who has got direct hyperbilirubinemia. So far, we know the definition of direct hyperbilirubinemia, what are the possible etiologies in broad context, red zone, yellow zone, and blue zone, and what are the main categories, and the specific diagnosis like galactosemia, tyrosinemia, where you would have specific management strategies. This is just to highlight you the general management. If you have a baby with direct hyperbilirubinemia, just like a reflex action, you need to start them on ursodeoxycholic acid. That's a very benign, innocent medication, but very helpful. It has got multiple actions, which I'm not going to mention in this talk. However, it's very important you start them at the outset. The dose is 10 milligrams per kg per dose, 3 times per day, and you need to continue verso till direct bilirubin comes down to 25. Afterwards, you can stop also. Fat-soluble vitamins, very important, and there may be children who come with bleeding due to vitamin K deficiency, so it is quite important. What's the use of phenobarbital? Phenobarbital in a baby with direct hyperbilirubinemia, we use in specific instances. If you have a baby with biliary stones, biliary sludge, yes, you might give a course of phenobarbital and see whether that improves, maybe 2 to 4 week course. Or sometimes, if you want to prime the baby prior to the HIDA scan, again, you are expected to give phenobarbital for 5 days to improve the utility of the HIDA scan, if you have decided to perform a HIDA scan. And in babies who are going to go ahead with cholangiogram, you will start pre-Kasai medications. If you have a baby with direct hyperbilirubinemia and scan had been suggestive of biliary atresia, or you are anyway thinking of going ahead with cholangiogram, you start them on certain medications thinking of Kasai. That is called pre-Kasai medication. Those are lactulose, ciprofloxacin, and metronidazole just to facilitate their fast recovery following Kasai. They have to undergo. Specific management like galactosemia, you will have to stop breast milk and start them on soy formula. In tyrosinemia, again, you manage their acute liver failure and start them on nitisinone. Monitor them, and when needed, you will perform liver transplantation. Gestational alloimmune liver disease, or sometimes it's called neonatal hemochromatosis, you perform exchange transfusion, go ahead with immunoglobulin. So specific management strategies for specific causes. But most of the diseases other than biliary atresia and few diseases I have mentioned here, it would be supportive care and finally liver transplantation. Other important aspects, nutrition. As I mentioned earlier, food is a medication to the liver. So it's very important we take extra care to improve the nutrition, enteral nutrition of a baby who have got cholestasis. It's crucial to improve their outcomes. Counseling is important because some of these disorders are genetic and metabolic, would run in families. If it comes to congenital infections, you might need to treat the mother and you need to counsel about future pregnancies. So it is quite important. And if you think about a course which would need liver transplantation or maybe Kasai, it may be good to have early communications with the liver transplant center. Certain babies with direct hyperbilirubinemia would have intense pruritus, especially when it's due to metabolic causes like progressive familial intrahepatic cholestasis, maybe bile acid synthetic disorders, allergic syndrome, sometimes biliary atresia as well. They will have intense pruritus, and you may be managing children who have got intense pruritus and scratching all the time. No sleep for the child, no sleep for the family. So what are the strategies you would consider when you manage a child with liver-related pruritus? There are general management strategies and medications. General management wise, you have to keep their skin clean and moist. It's very important you use moisturizers and keep the skin clean. You may advise to cut their nails short and use emollients. In addition to that, you can use antihistamines and other medications like cholestyramine, which is very effective in children with biliary atresia as well as allergic syndrome. And you may use rifampicin and naltrexone as well. The limitation of rifampicin is a very good antipruritic. However, the limitation is in our context, we do have a lot of cases of tuberculosis, and it's a medication which is used for tuberculosis. So your chest physician might not be happy for you to use it for the long term. What I do is, there is intense pruritus. I start with a high course, like several medications, maybe including rifampicin in intense cases, and then you come down in the medication. That had been quite effective because you get the reassurance from the family. Okay, they see that pruritus is coming down. Then when you come down in medications, then their compliance is better. You can use rifampicin in the initial period and then stop, rather than using for long term. So, coming to the end of the talk, I would like to highlight these take-home messages. We discussed about evaluation of a baby with direct hyperbilirubinemia. Any child with direct hyperbilirubinemia and pale stools, please consider biliary atresia unless proven otherwise and make that a priority to exclude. Biliary atresia and neonatal acute liver failure emergencies which could come under red zone. So firstly, think about these two if you have a baby with high direct bilirubin. Other possibilities could definitely wait. Cost-effective diagnostic approach is very important in the current context, I believe. Rather than performing all the investigations like metabolic screening, liver biopsy at the outset, you might consider a stepwise approach and consider genetics instead of liver biopsy in the current era. Nutrition is very important. Make an extra emphasis to the family and to the team about nutrition. And early shared care with the liver transplant center may be helpful in certain conditions. That makes me to come to the end of this talk, and I would like to end my talk with sharing this little success story. So this was an infant who was referred to us in December, early December, with acute liver failure. He was actually an infant when he was referred. He was 11 months. And he suffered from acute liver failure. He did have direct hyperbilirubinemia. The underlying etiology was not found, and we concluded as seronegative hepatitis and genetics are awaited. So this child underwent successful liver transplantation in December and now enjoying the life at home. With that story, I would like to conclude, and I'm happy to take up any questions if there are any. Thank you so much for your listening.
Thank you very much, Meranti. It was very informative, and you elaborate all the important aspects in a very simplified manner. I think there will be a lot of questions with your sessions because this is something everyone is interested to know. And I can see about nearly 100 participants for today's session, and which is a great achievement. So we'll wait for questions. I would like to ask one question from you until we get further questions. Meranti, what is your experience with regard to referrals regarding biliary atresia? Are we referring at the correct time or are we late? Do we need to improve it further? What are the common problems or the delays you encounter with regarding to referral with direct hyperbilirubinemia patients?
Yeah, thank you so much, Dr. Jitma, for that question. I think that's very important. I did emphasize on biliary trace at several occasions during the talk as well. I think if we go back 10 years and compare the situation now, I think we are much better in referring early referral of babies with direct hyperbilirubinemia in view of biliary atresia. I do get calls from neonatologists and pediatricians, and I can see they are panicking and they are rushing if they have a baby with biliary atresia. When I say, can I get back to you in 1 hour, they would say, okay, this is urgent because I'm suspecting a baby with biliary atresia. So that makes me quite happy because they have that urgency. Having said that, sometimes the false reassurances, the reasons for the delay, as you asked, one is the declining level of direct bilirubin. As I mentioned, if you have a direct bilirubin value of 70 to 80, sometimes people would say, this is kind of a low value, it's not in 100, so they might wait. And if you perform it today, if you perform it in 3 days' time, if it has come down a little bit, you might get reassured. That is actually out of many. And another aspect, if I think of, sometimes people have a belief, if there is no hepatosplenomegaly, this can't be biliary atresia. Specifically, if there is no splenomegaly, no ascites, this can't be biliary atresia. Actually, you will expect splenomegaly if there is portal hypertension. So that would take some time for the portal hypertension to develop. And if you have ascites, that means you are late. So do not exclude biliary atresia because there is no splenomegaly, no ascites, because it's late. If you have a baby who has pale stools, who's having direct hyperbilirubinemia without these features, yes, you are winning, you are early to diagnose biliary atresia. So don't get reassured with the absence of splenomegaly, ascites, and decreasing levels of bilirubin. So I think we have improved with the use of stool color chart and with the knowledge which has been spread around. But I think we need to improve a little bit further with the use of the stool color chart, encouraging the families to use it, encouraging the clinical staff to use the stool color chart, because some people actually don't know that exists in the CHDR, and early referral. Yeah.
Miranti, I'm Dr. Saman Kumara. Thank you very much for your talk, and it's really impressive. Thank you so much. I just want to what do you say? I just want to emphasize one important thing. As you said, delayed presentation of babies with direct hyperbilirubinemia. I think in first place, one thing I have noticed is it is obviously very important when you have a baby with direct hyperbilirubinemia to investigate. But when you have a baby with jaundice, I'm referring to a term baby who is still jaundice at 2 weeks of age. And sometimes people do not diagnose conjugated hyperbilirubinemia because they do just missing the chance of doing a bilirubin level. And because sometimes you reassure yourself, okay, this could be breast milk jaundice, which is very common, absolutely common. So it's very important that you do a bilirubin level, at least just to do a bilirubin level and see whether you are dealing with conjugated or unconjugated bilirubin. And then it's up to you to then decide and further investigate this jaundice, whether it is conjugated or unconjugated. But people sometimes don't do a bilirubin level when the baby is presented after 2 weeks of age, and just thinking where babies, as you said very correctly, the stool color, go by the stool color, because stool color still can be normal and it can be misled by dark urine also. So it's very important to at least to do a SBR level and look at the direct fraction as well, and not to miss this. So that's one thing. And one quick question for you. What is your experience with liver transplant in the small babies? And it may be overseas experience. Or I'm sure it's not done here, right, in Sri Lanka for small babies, maybe infant. What's the place for liver transplant?
Yes, sir. if I talk about the experience here in our center, Ragama, we have completed 13 liver transplants so far with all this COVID-19 pandemic and the economic crisis. So we consider it as an achievement. And the youngest child we have performed is the one I shared, the 1-year-old child who was presented just before his birthday. So we have not performed children so far less than 1 year, but we are thinking to proceed with less than 1-year-old now on. So that is our current experience in Ragama. If I talk about the place for liver transplantation for small babies in overseas, the youngest one I have seen there was a day 5-old baby who was transplanted for neonatal hemochromatosis or gestational alloimmune liver disease. So it's very effective. I've seen the outcomes in the clinics where the babies who have been transplanted less than 1 month and they are coming to the clinic at 14 years, 15 years, doing absolutely well, just on immunosuppression. The common indications I've seen were, if I talk about infancy, less than 1 year, the indication for liver transplants in Birmingham, the commonest one was biliary atresia, the unsuccessful size and delayed presentations. That was the commonest. And out of the metabolic ones, there had been tyrosinemias and there had been PFICs, the severe phenotypes of PFICs. And also there had been gestational alloimmune liver disease where they have not responded to plasma exchange and immunoglobulin therapy. So outcomes have been quite impressive, and they do perform it even less than 1 week, like or even neonatal acute liver failures. So those were the main indications actually. Yeah.
Thank you, Miranti. Thank you very much.
Thank you, sir.
Miranti, one more question with regarding the portal hypertension. Have you encountered the babies who later presenting with portal hypertension who has had initial history of umbilical catheter insertion? Because we know if it is malposition, there is definite chance of having the portal vein thrombosis, and later they can present as portal hypertension. There are certain things from as neonatologists or pediatrician which we need to do, such as ultrasound scan to identify the position of umbilical catheter. So what is the experience in portal hypertension occurrence in our babies or the children secondary to umbilical catheter insertion?
Yeah, it's like this. I'm sure our neonatal care has improved remarkably, and I may be seen, if I see 10 children with portal hypertension who have had umbilical venous catheterization, but you might have saved maybe 1,000 babies by putting umbilical venous catheter. So it's not with the negative thing I'm looking at it, but yes, it's quite common from the cohort I see with prehepatic portal hypertension, not the hepatic, the portal vein thrombosis ones I'm talking about. Prehepatic portal hypertension ones, it's quite common. Maybe if I say 10, there may be, if I take 10 children, 5 to 6 like they have had umbilical venous catheterization. But I do understand it's been put for a purpose, and you might have saved 1,000 children with umbilical venous catheter, and maybe very few are ending up with this complication. To answer your question, yes, I do see them, but retrospectively, I do not really know what we would have improved. One thing I would say, the treatment of omphalitis, because umbilical venous catheter would have been put for a reason, and maybe in the follow-up you can examine them for splenomegaly, detect the portal hypertension early rather than waiting for them to come with a GI bleed. So that is one aspect where we would improve, because if a baby has had umbilical venous catheterization in your neonatal and infant follow-up, you may look for the splenomegaly actively, because this child has had an umbilical venous catheter, and screen for that, where you can preemptively plan your endoscopies and prevent them coming with acute GI bleeding. That is one thing I would think of, and the other one would be the treatment of optimal and complete treatment of omphalitis. That is important, because that is again etiology where I see in prehepatic portal hypertension.
I can see some comments about your prompt response for our daily concerns regarding the babies with direct hyperbilirubinemia. They are really appreciating your service. Thank you very much, Meranti. I think in the absence of further questions, I would like to conclude the session today. Once again, thank you very much for this informative lecture that will be definitely helpful to improve the neonatal care and the infant care in our country. Thank you very much. Good night, everyone, for your participation.
Thank you.